Good afternoon, everyone. Welcome. So the title of this symposium is The Rise of Big Cannabis, Explorations of Legal Marijuana, as well as Implications for Saskatchewan. My name is Lucas Richert. I'm a sessional lecturer in the Department of History. I have interests in the history of the body, the history of the pharmaceutical industry. My book from last year is called A Prescription for Scandal, which won a book prize, the Arthur Miller Center Book Prize. The other co-organizer of this event is Dwayne Moore from the Department of Philosophy. Dwayne Moore has a specialization in contemporary analytic philosophy of mind. He's published over 10 peer-reviewed papers, and he recently published a book called The Causal Exclusion Problem. So thank you, Dwayne. I'd like to make a few remarks and just thank a few people before we really get started. I have to thank the Vice Dean of Research, the Canada Research Chair in the History of Medicine, the Department of History, Department of Philosophy, McGill Queen's University Press, University of British Columbia Press, and particularly the Histories of Substance series. I'd like to thank Communications here at University of Saskatchewan, Active History, Star Phoenix, the Johnson Shoyama School of Public Policy, and finally Shaw Cable. So that's out of the way. Lots of people to thank. I'm going to now pass the mic over to Lisa Kalinchuk. She is the Interdisciplinary Dean of Health Research. Thank you.
Good afternoon. It's great to see so many of you here for this wonderful event, and I note the presence of a lot of students, and I think that that's fantastic for a symposium of this nature. A key function of any university is creating knowledge. It's a task that demands creative minds, trained in critical thinking, working in an environment that both fosters creativity and provides the latest tools to support their work. As a member of the U15 group of top Canadian research-intensive universities, the University of Saskatchewan is an ideal setting to foster the discussion that you are about to have today. As we all know, the consumption of marijuana is a hot-button topic. The study of cannabinoids and how they affect human physiology, brain function, and behavior is a rapidly growing scientific field. And yet, there are barriers to research progress in this area that need to be removed to facilitate progress. At the same time, debate about the legalization of cannabis is a public one, having reached all levels of government and many dinner table conversations across the country. It is clear that we need evidence-based discussions of the issues, and a symposium such as the one you are participating in today is one great example of how to engage in those kinds of discussions. Therefore, I encourage you to use this opportunity to share your ideas and to listen to the ideas of others. Ask hard questions and be open to whatever answers you hear. You will learn something new today, and your thoughts and opinions about medical and recreational marijuana may be changed. To that end, I am extremely pleased that members of our departments of history and philosophy had the foresight and leadership to organize this symposium at the University of Saskatchewan. You may be interested to know that our university has contributed quite significantly to our understanding of the effects of cannabis on the brain through published research. For example, it was U of S researchers who were the first to report that cannabinoids can have anti-anxiety and antidepressant properties in animal models by directly affecting the morphological characteristics of specific types of brain cells. This research was published in the prestigious Journal of Clinical Investigation. Of course, the field has moved on since then, and many more data are available on this topic, but I still present this original paper to my students when I teach, and it always instigates a vibrant and fulsome discussion in our class. So without further delay, On behalf of the Vice Provost Health, Preston Smith, all of the Health Sciences Deans and myself, Associate Dean of Interdisciplinary Health Research, I wholeheartedly welcome all of you to this symposium. I'm sure that it will provide a fruitful and stimulating discussion, and I wish you all a wonderful afternoon.
Thank you kindly for those words, Lisa. Let me now introduce our keynote speaker for the afternoon, Brent Zettel, co-founded Prairie Plant Systems in 1988. 2 years later, in 1990, he received his Bachelor of Science degree with distinction. 1 year after that, he became president and CEO of the company. Since then, Brent's leadership has allowed Prairie Plant Systems to continue to focus on biopharmaceutical production. And the most significant advancement has been the awarding of the Health Canada contract in December 2000, where Prairie Plant Systems became the sole supplier to Health Canada. He takes pride in contributing to his field through his involvement on the steering committee for the Agricultural Biotechnology Industry Conference, as chair of Ag West Bio and chair of Gravity Brain Learning. In 2014, Brent was awarded the Ernst & Young Entrepreneur of the Year Award for the Prairie's Business to Consumer category. So please join me in welcoming Brent Zettel.
Well, isn't it a sunny afternoon to talk about medical cannabis? Thank you for those kind introductions. Just one little point of clarification, because I know the Ag West Bio folks are here. I'm the retired chair of Ag West Bio. It was a great event to be with them, and certainly my passions in agriculture still exist. In fact, that's how we based our company to start with in the whole arena of medical cannabis. My goal today is to talk about the journey of medical cannabis within Canada, what led up to this point in history within our country, and what perhaps our involvement of it has been up to this point, and maybe not as insignificant or inconsequential, but I think I'll let the audience judge that as we go along. So to mitigate against potential bias, I have 15 years, and one of the guys that started within the program, 20,000 person hours, but as an organization, we probably have in the neighborhood of 500 person years worth of experience in the medical cannabis field. We're trying to do it with Health Canada, or providing it to Health Canada since 2000, and as best practices go for GMP, under GMP practice. We are also a provider of product for clinical trials, both the ones that we sponsor, but also ones that are ongoing or starting to commence. And I'll be using generic names as through the program, just to make sure that it's protect the personal information of individuals that are involved. So I put this slide up, and the journey. As you can see, it's not always straight, clear cut, but we need sometimes a lot of directives to get into where we're going. And I think that as we look at this space, there's going to be lots of signs of where we're going, lots of things that we have to do. And where is the industry going to be going in the future? So in the beginning, some of the earliest evidence that we have of medical cannabis dates back to China, around 2000 BC. And it was in cases involved for gout, rheumatism, malaria, absent-mindedness, and a couple of other things that go along with it that was documented. So we find that was the earliest evidence we have of medical cannabis. Then there's a reference of it in the history in the Athra Veda, the sacred text of Hinduism, from 2000 to 1400 BC. It was referred to as a bang sacred grass. And it was included as a relaxant and an analgesic at that time in those sacred texts. So you can see from the Asian origins, it's been used for quite a long time, almost as a form of coevolution of our well-being. Even the Queen Victoria herself had used it for managing pain at some point in her labor. Moving on to Dr. Osaneze reports some of the effects of properties of medical cannabis. He was first published in 1839. He was first of about 100 papers documenting marijuana's medical use in the 19th century. Of course, that sort of led to some of the, in 1840 to 1900, numerous other articles were written, and extracts of cannabis were adapted by the British and American pharmacopoeias at that time. Now the bad news. It became illegal in Canada in 1923, and there was the Marijuana Tax Act of 1937 in the US, and the removal from the pharmacopoeias in 1937 and 1941. Why would that happen? Well, if you read some of the background, what the understanding is that hemp was a fiber, was of great value, but was easily grown and was used for lots of things, for fiber, for paper, and for all other industrial applications. And there was a couple of other colliding interests, that which a powerful senator had many forested lands of timber that he wanted to make sure timber fiber was going to be used instead of hemp fiber. And at the same time, right around the same time, nylon was invented by Dow. And the two ganged up to make sure that they wanted to stamp out the competitor hemp, to make sure that hemp wouldn't be used as a fiber source going forward. There's also some suggestions that there was some racial undertones in terms of trying to make this because the other sides of society, black Americans, were using it, and it was considered to be racial, as a racial assault, really, in that time. So that's what started the process of the prohibition. It was in 1937. It was for financial and political reasons that were really seated in an anti-competition instance for hemp. That's what got the whole thing started way back when in 1937. So come along, we move along into the drug commissions of the 70s. There was three of them. There was one, the Bond Commission in the Netherlands in 1972. There was the Schaefer Commission in the United States, 1972 as well, under Nixon. And there was the Ledane Commission in Canada from 69 to 72. Now, Gerald Ledane, he chaired the commission, the inquiry, and he was the guy charged with doing this. And it just so happens, who was the prime minister at the time? Pierre Elliott Trudeau. Ironic, isn't it? Where we are today. But there were 365 submissions, which also included, by the way, an interview with John Lennon. At the end of it, the three individuals, Gerald Ledeen, Heinz Lehmann, and Peter Stein, they recommended the repeal of the prohibition against simple possession and cultivation of personal use. And they made that recommendation to also look at a policy of distribution and removal of cannabis from the Narcotic Control Act. Generally, the recommendations of the federal government to conduct research and patterns of use, effect on health, personal and social behavior for controlled legal distribution. That was in 1972. The results? Well, they were aimed at reducing social risk. They said that the social risk was manageable within the context of removing this from the things. All three commissions' recommendations were generally seen as supporting decriminalization and destigmatization of medical cannabis or cannabis in general. Now, the Bond Commission in the Netherlands was accepted. That's what gave rise to the coffee houses in the Netherlands, the infamous coffee houses. The Schaefer Commission under Nixon, the rumor is it was thrown in the garbage. As soon as he got it, he looked at it and he threw it in the garbage. That was rumored of the Nixon Commission. The Ledane Commission was ignored. And there ended the initial launch to move cannabis into the forefront again. So we had an involvement, running a parallel track now. Our involvement as a simple biotech company in 1988, moving into all the different things. Our entry into this market was in 2000. And in 2000, and I'll talk about this in a minute, the idea was the government, based on a case, was compelled to look at compassionate access under the Charter of Rights and Freedoms, Section 7, for people who were wanting to use it as a medicine. And in 2000, the government created the MMAR, Medical Marijuana Access Regulations, which basically identify the patients who could, under a physician's screening, could submit an application to Health Canada, and then they could have, from there, be given what's called an ATP, an authorization to possess, and they could grow the material for them or have somebody grow it for them. And they gave out the contract, which we were one of the few bidders, to do medical cannabis for clinical research. That was in 2000. Now, I'm going to deviate from the history and just talk a little bit of the dovetailing of how we got to there, and then I'll come back to the industry as a whole. So, as an organization, that's how we got started, believe it or not. It was in 1990 when Hudson Bay Mining and Smelting out of Flin Flon asked us to set up a growth chamber underground in Flin Flon, Manitoba. And without much experience in growing plants underground, and I have a long story that I shared with the class this morning, in a cold and dark space, 1,170 feet below surface, we actually created a growth chamber to start looking at production of plants using this secure underground facility. At the time, in 1990, we were looking at crops that could be used for economic development or things that would make sense within the context of the town getting some value and of the value that would come in terms of looking for the next economic development. Food was one area that we looked at, tomatoes. It's funny because the fellow that worked with me, his name was Ron McNeil. He's proud of the fact that he was helped with the underground garden. And he was a fellow who said that he compared everything good to life to a tomato. Everything was good tomato. He compared having a good night to eating a good tomato. He compared his wife, how beautiful she was, as a really nice tomato. Everything was good. So we had to grow tomatoes. Right? Roses were the second crop, and Saskatoons were the third, because that's how we started life. Well, the roses, we produced 1,100 roses in 3 months, long stem roses from 80 plants. So the challenge became, well, what the heck do we do with all the roses? Because they're long stem roses. So for those early years, we thought we'd start with a little business, and we'd start selling them to the local flower shops. It was okay until they started fighting, the two flower shops, over their share of the quota and making a noise at the highest level of Hudson Bay. In which case, we were denied to stop selling. We were told we couldn't sell any more roses to anybody else. So then what happened? Well, we said, well, what are we going to do with these roses? So in order to maintain the rapport with the guys of the mine, because either they buy into the story and they give you the support, or they look a way of sabotaging and stealing from it. Well, we said, we need to get their support. So guess what? Every 2 weeks we go up, we'd harvest the roses, and we'd give them to the guys. They were at the head frame. But pretty soon it became like Pavlov's dog. Give these roses, and they'd all be lining up for the roses. Well, it didn't take long to figure out why they're lining up for the roses, because they were thinking, tonight's the night. As a consequence, it was really favorable for them to be able to get these roses. And we said that we mildly joked that in those years in Flin Flon, actually, the population of Flin Flon rose a little bit when we were giving out the roses. That's how we kind of got started in the process. So the crops we also grew were things that we thought of commercial value. This is in 1996. That original picture, by the way, the roses, was taken in 1991. Funny thing is, I had to dig these up from the archive from slides, from Kodak slides, and our IT guy had never seen a Kodak slide. I thought, holy cow, time has passed by. So we had to digitize a lot of these slides because they weren't digitized yet, right? So we grew canola in the mine because, of course, we're a good Saskatchewan-based company. We have to see if we can do this for research. Sweet basil, we tried to break into the fresh herb market at that time before sweet basil was, fresh herbs were really popular. And this is tobacco. And this is actually in our facility in Michigan. And we had a contract just prior to the Health Canada awarding the contract with Health Canada to do a glycoprotein engineered tobacco plant, which these are. And the glycoprotein engineered part was used as a diagnostic for cancer potentially, as they had expressed in the seed. And they needed a seed-to-seed production system. And we did it underground in a secure environment under APHIS and got a license to do that, which is where the value of looking at using contained production facilities was spawned. We could see that the convergence of pharmacy and plant biotech was coming together in the late 90s. And the big biotech companies ran aground with their corn platforms. I don't know if any of you remember starling corn. Starling corn was a Bayer product. First it started with Herx, was a Bayer product, but what happened was they got a license to grow their, again, the same thing, a diagnostic protein in a corn plant in Indiana. The first year did okay. The second year, they didn't pay attention to the volunteer corn coming up, and it contaminated the entire crop of the Indiana production in the 1 year in 1996. 3 years later, Bayer settled out of court for $495 million because they quarantined the entire crop. The problem was, big biotech decided they weren't going to do pharmaceuticals in their corn platforms, which is where we thought our business model was going to come from. Okay? So plants, designing them to make medicines was where our ilk was. We thought that that's the direction we were going to go. And that's why the proteins were important. So late in the late 90s, we were scratching our head wondering how we're going to build this model because we can see the science is catching up. Where's the value proposition for society? And it was then that serendipitous that Health Canada put out the RFP for the medical marijuana contract. I got asked earlier today, how did we exactly get into this business? I didn't wake up one day thinking I was going to be a grower of marijuana. In fact, I had never seen a marijuana plant until I grew it the first time. The oldest of 11 children, Catholic, born and raised, had to be the example. We did sports, and we drank. On a farm. I was on a farm. That's how we did our recreation thing. So I had never seen a plant until I actually went underground to actually grow it. So we were awarded the contract in 2000, and so then we had to move locations from the existing because it wasn't big enough. So this is what the surface looked like. It's called the Trout Lake Mine. It's just outside of Flins Lawn. And the mine went under the lake. So we went to look at chambers under the lake. And as it goes down in the mine, it's a decline mine. You drive down, and then there's levels that they go level where they were taking out the ore. It's a copper mine, copper and zinc mine. And so what we did is we selected a spot that's 480 meters below the surface, below the lake. It's a little daunting, but I keep telling anybody who get underground, after 6 feet, it doesn't matter. Really, after 6 feet, it doesn't matter. So we actually then looked at what would it take to develop that site. Well, the results of that were that. That was our third growth chamber. We had to design the lights, design the irrigation system. We had to then figure out how to grow the crops in a contained environment. And the reason the government had looked at using this or awarding this is because they really wanted a secure location. The last thing they wanted was to wind up with some product that they were mandated to produce or gave a contract that was going to wind up in somewhere in Montreal. They didn't want that embarrassment, especially from the international stage. So they wanted something that was really, really, really secure. So we built the security system around it on a outlet of 480 meters below the surface in the hard rock mine with a lake over top of it with one entrance in and one entrance out, except for maybe egress on emergency. And the people that would, if there was ever a danger of somebody breaking in or getting alarmed, that's okay. Our police would show up. If that was ever to happen, it didn't happen, but they would show up and they just eat a sandwich and wait and have a coffee and wait for them to come up because eventually they got to come for air, right? Just like gophers. Eventually they got to come up, right? So we just wait for them. So at the time, who was responsible for that was the Minister Rock. He was the minister responsible for helping to get this started, and he actually came to the ribbon cutting event in 2001 that we had with the underground mine. And Minister Rock, he was a great guy. Actually, he really was helpful. He was very promotional of thinking that we got to move this. He was the brainchild behind the CIHR, the Canadian Institute of Health Research, that was giving money in order to allow for the continuation of medical cannabis research for clinical trials. He put a fund together. He was the health minister at the time. A visionary when it comes to this stuff under the Chrétien government. Is a really strong supporter of the program. Of course, after his time, he went to justice, and then it went downhill after that, frankly, with all the other ministers because they were afraid of it. They were afraid of the different programs that were coming out. But he was very, very supportive of what we had to do. Just a picture of what the bud material looked like under the lights underground. And the little note here, and I'll reference it, in 2003, the Hitsing case, and I'll talk about it in a second, was what then the Ontario Supreme Court, Mr. Hitsing, challenged the Crown to get access to the Health Canada supply. So in 2003, the Ontario Supreme Court ruled in favor of Mr. Hitsing that he should be granted access to the Health Canada material that they produced, which was the material we produced. The Health Canada Crown turned to us, and they said, okay, start producing cannabis to sell. I said, what? We're doing this you guys didn't define anything that we have already. We're just making clinical trial, and you're asking us now to start making something for patients. It's never been tested, never been tried. So they commissioned the RCMP to do a survey of all the convictions in Canada to find out what the percentage of THC the population is using on a national average. What the population. And they took 100,000 data points from the DAS labs, the Drug Analytical Services labs, that they had used as part of the convictions, as evidence for the convictions. 100,000 data points. The national average at that time was 9 to 10% THC. So they asked us, so at the time also the story goes, there's always been this tug of war between me and Health Canada, or us and Health Canada. We've always had this love-hate relationship. Sometimes it's hate-hate. It's never been love-love, but it's mostly been, love-hate, okay? That's even as recently as the recent inspection that we had, and I was listening to Mariana's Trench song as I was driving home, and the song goes, "This means war." I said, well, that's fitting after today's inspection. That's the name of the song. Anyway, so when we got through this, we were determining what we have to do. Health Canada said, well, what are you going to start producing? I said, well, we need some seed. Give us some seed. I said, we've got to get some seed from somewhere. Well, it's illicit. You can't, at the time, that was when they were busting everybody for possessing seed. So I said, well, why don't you go find some around the world? Sure. We're going to go find some around the world. Where? Well, we hired a consultant from Ottawa. He had 3 colleagues. One was in Russia, one was in Central Europe, and one was in Africa. And the way it works is under the Controlled Substance Act, you have to come from the country of request to the recipient country of origin in order to get the seed transferred. It has to come from government to government, federal government to federal government, under the Controlled Substance Act and the 61 Convention that I'll talk about in a minute. Well, let's say that's fine. So we gave out the 3 names, and as it turned out, Health Canada contacted those 3 names. It turns out all 3 of those researchers were working illegally, outside of the confines of their license, and they were all consequently incarcerated. That's really a great start, right? Here we are, and we have a growth chamber ready to go. They're asking us now to start producing clinical trials, and we have no seed. So I went to the CBC. That's ridiculous. They put us on contract. They aren't paying us. We've shoveled all this money. We got no seed. So guess what happened the very next day? We got a courier package from Health Canada from about a half a dozen successful conviction cases, the evidence that wasn't destroyed. Here's the seed. Find us some. What do you mean, find you some? Find us some. So they sent us seed for a period of 18 months, undefined bags of seed. And we had to go through a screening process to find something that would work in this 9 to 10% range. It was a selection program. Of course, they didn't want to pay us for any of that stuff. They just wanted to make sure that we found them the right seed. So we went through the exercise. We received probably in the neighborhood of 85,000 different lines. At the time, we screened through probably, in terms of seeds meaning can represent a different line. So we got individual seeds. But we screened through about 25,000 different individuals to select 12 plants. Now we got the 12 plants. We picked the one that we thought that made all the right criteria. We gave it to Health Canada, and it was a 12.5% or 14% THC. It was fondly known as a 338 strain. Now, interestingly enough, not knowing what plants look like, interestingly enough, every plant, as we know, has a terpene signature, has a different smell. And the staff would start to name these things by their smells, not by their numbers. But they would say, oh, that's cotton candy, or that's jack pine, or that's blueberry. So they all had different smells. So ultimately what happened is that we then looked at how we could then streamline this into something that Health Canada would accept. So we gave them the strain. They looked at it. They looked at the report, and they said, 12.5%, 14%. Okay, water it down. That was the order. Water it down with what? Water it down with leaves and twigs. I said, why? You know that we're going to get slaughtered. right, in the press. Because the average user who uses it is going to recognize there's leaves and stems in this material. Watered down. Okay, well, I think the people who followed history know what the outcome was. It was bad. It was all bad. And then conversation thereafter was, told you. Now, can we just give out bud material? But to this day, that flin-flon material that Health Canada produced did not break the stigma for 10 years. We did not break that stigma for 10 years. But the product was at 12.5% THC, which was a margin above the national average. But we never did break that original stigma. It was always stigmatized as being not good quality. And that wasn't true. But we did ship it out in this format. Well, coffee pouches at 338, but it was 12.5% THC, and it was a milled product. Ratchet forward to today, this is under the MMAR. I'm going to finish how we got involved and then go back to the sort of overall program. That's what the products look like today. Under the new program, under CannaMed label, now we can sell direct to patient. Before, we were selling on behalf of the Crown. And we also now have, since January the 12th, we've been allowed to sell oils. And that's thanks to the Smith case that just happened this past July that forced the federal government to make derivatives available for their patients. And so they allowed the LPs to make liquid or derivatives of cannabis, but the criteria has to be that it's liquid at room temperature. So once again, we're at a restrictive nature, and they're doing this in baby steps. And you'll find out through the theme that the federal government's been resisting every step along the way, and the courts being the ones dragging them through it and making the changes, forcing the change. And under the medical auspices, they're able and very successfully, I don't think the government has won a single case in the last 5 years. Very successfully, they're using it on the basis of Section 7 of the Charter, which is right to have a better life. So now that we grow it, we follow, it's given the good manufacturing practices, but most of the licensed producers follow a GPP practice. We're not allowed to, we don't use pesticides in the product. We test for microbials and mycotoxins, and it's an online pharmacy. So I'll talk about the structure in a minute, but then we supply it right to the patient's door, and we try to make it as consistent as possible because of dosing. And that's because the patients are using it at somewhere between 1/10 and 100th the dose it takes to use it from a recreational purpose. So they're using a much smaller subset to manage their symptom and get on with their day. That's in the classic case. So that's why they wanted to have it as consistent as possible, because it has to be done in the smallest. For them, they're taking the smallest amount. An average patient consumption that we've seen from a buying pattern from about 6,000 patients now is about 1.1 grams a day. That's the average consumption from a patient that we have. Now, they're writing scripts for between 3 and 5, but we're finding that their average consumption is about 1.1 a day. So that's just an example of the microbial counts that we have to do. And of course, we have the good people in the lab that we've had to set up our own validated methods and looking at the potency to make sure that and this is an HPLC method, that we have a really qualified, dedicated, hardworking staff that always keep it on track. And we do a profile for 7 different cannabinoids. I think it's 7. It could be more now. It could be getting up to 9. There we go. And so we actually do the extract, and then we put it into a machine for testing. It's called a high-pressure liquid chromatography. The chambers today, they're very much the same. This is what the new chamber looks like today, and it's a canopy type of production system that we use, and we bring and harvest the bud. The leaves and the stems are incinerated because we're at such a volume that we can't keep track of them. We just incinerate them, but we only produce the buds, which for most of you may know that they are female. They're cloned females. There's no male plants. It's a very bad life for a male plant in our facility. It's executed on site. So talk a little bit about the botany, and then I'm going to go back to policy. So from the botany perspective, it's closely related to hop. It's in the Cannabinaceae family. It's an annual herb. Dioecious, male and female flowers on separate plants. Now, we have seen transvestite plants where they have both, or they have they're monoecious, essentially, where they have both on the same flowers on the same plant. But those are unusual. those get executed as well, unfortunately. But we have just the female plants, but they're separate plants. And the active ingredient is really found on the female flowers, and it's the trichomes. And the trichomes are found, I know this pointer works. There. The trichomes are found on the top parts of the plant as it's flowering. And as we follow through, it's actually the trichomes are these little hairs that have the globules on top. And they secrete the oils in these glands, and the oils then have where the cannabinoids are manufactured, on the very outside of the plant. That's where it's manufactured. Hence why when we're making it medical, everything that's outside on that plant is going to also be consumed by the patient if you're presenting it. So that's where the molds will be, that's where any pesticides residues will be, that's where anything that's human hair will be. In fact, Dad's told us a few stories that they had one sample come into their lab that had 2% by weight cat hair, okay, as an example, right? So everything that's on that plant is going to be there. Now, so another shot of it is that's what the close-up at the top looks like. Typically, the higher the concentration of the trichomes, the greater the cannabinoid profile. Now, the plants produce quite an array of phytocannabinoids, but most people know that delta-9 THC, or tetrahydrocannabinol, is the one that the cannabis plants that most are pulling from, but also cannabidiol, or CBD, is the other one, the two most common phytocannabinoids are doing, and I'll talk about those in a second. But where they're actually, the secretory glands are at the base of the globule, and in this cell, then it secretes in terms of this cavity, and that's where the product is. Of course, as many folks will know, that's what hash is those trichomes that are taken off. That's where the word hash comes from. So, but the discovery of the THC came originally 50 years ago from Dr. Meshulam. He discovered this phytocannabinoid, THC, which is why he discovered it on, guess when? 420, which is why we celebrate 420 today, on that 420. So that was when he discovered the actual structure of the THC molecule as a phytocannabinoid. Okay? And THC and CBD are the two compounds, as you've seen there, but these are some of the other cannabichromine, cannabigerol, THCV, CBN. We measure for all these. Those are all different types of cannabinoids that potentially have phytocannabinoid or maybe have pharmacokinetic impacts. Now, there's 110 known phytocannabinoids the plant produces. We're only really managing right today 2. So really we know that at least 5 are psychoactive. So it does open up the idea that there is some science there that could be unleashed in terms of other type of cannabinoids that could be done. I'm not going to talk, I'm going to be running short of time if I talk too much about the works, but THC and what it's being suggested anecdotally that it's being used for, and you can see at the bottom there what they're considering it as being used for. And also from a cannabidiol point of view, anti-inflammatory, anti-seizure, in terms of those are the suggestive treatments that they're being used for today. And the reason that they're effective is it's something to do with what's called the endocannabinoid system. Everybody in this room has cannabinoids in their system. Then we naturally produce something. It's the operating system for the human body. And it's funny because when you have doctors teach other doctors, they'll ask the question at first, how many of you have cannabinoids in your system? And not a single doctor, or maybe 1 or 2, will put up their hand. Then he'll explain this endocannabinoid system and how that it works for improving. It's a natural operating system for managing appetite, pain sensitization, mood, and memory. It's our natural system for operating for maintained homeostasis. He'll explain the system, and then he'll put his pen down and say, okay, now, how many of you have cannabinoids in your system? And he'll only get about 25% of the doctors to put their hand up. It's still getting behind the curve on this thing. But that's the reason why it works, is because we naturally have receptors, CB1 and CB2 receptors, that respond to the phytocannabinoids, or the cannabinoids that are produced in the plant, can mimic our natural system. That's why we respond. Now, interestingly enough, the native form of THC is THC acid. There's a little acid group on it. It's not psychoactive to human beings because it has the wrong structure. As soon as you heat it up, decarboxylates, the acid group breaks off. That naked molecule, the THC molecule, is then what's psychoactive. So It's a very succinct, a very specific type of molecule that we respond to. But there is that reality that we as human beings have somehow co-evolved to a certain degree that we respond to this drug. Not so unlike the receptors, the opiate receptors, where we respond to opium in the different types of opium drugs. But as human beings, we respond. That's the science behind it. And they are actually the receptors, CB1 and CB2 receptors, were discovered in 1991, and 1990, 1992, I think, and the receptors. So that gave evidence that we do have receptors that then the phytocannabinoids are responding to. There's about 1,000 papers now that, or better, scientific papers. The most recent one came out with Dr. Mark Ware in July. It was published in the Canadian Journal of Pain, as it was the COMPASS study was called, and where he measured for a period of 4 years, which the product that we had supplied, the different safety profile and some of the adverse effects of about 215 individuals over that period of time in 7 centers, and compared it to a comparable group, a placebo, not a placebo, but a control group. And he found, and there's more and more evidence that's coming out in terms of clinical trials and everything. So the science is starting to catch up behind us. Now, the problem is there's the compassionate access versus the science. We normally have a system that allows for the science, leads, and then the laws falling behind. But in this particular case, the appeal, that's the landmark case in 2000, is what started us in this process. Again, the courts dragging Health Canada through the process. That's what gave rise to the MMAR. As I mentioned, the HITSING case of 2003 is what gave rise to Health Canada now providing it to the patients. And of course, then we were the supplier to Health Canada for that period of time. The process was a simple one in the sense where it went through a physician had to recommend it to Health Canada. Health Canada acted as the authority. They granted the authorizations to possess to the individuals, and then the patient could decide if they wanted to grow their own, have somebody grow it for them, or access it from the Health Canada side, and then they would then tell the Crown which way they were going with it. Now, patients who wanted to have access to medical cannabis at that time under the MMAR had to qualify for one of these 7 conditions. 8 conditions. 8 conditions. If they didn't qualify one of these 8 conditions, then they weren't allowed to get access to it. So they had to fit underneath one of those 8 conditions. But the percentages relate to, from Health Canada's standpoint, what the percentage we're using it for. And you can see pain was part of this, but severe arthritis, so it's 36% was the biggest part. Spinal cord injury was another big chunk. But we're finding that that was what Health Canada deemed as acceptable. So these were the conditions that were allowable to receive medical cannabis under the MMAR. They had to prove, the doctor had to testify that they had one of these conditions. The new program in 2014 when it took over, actually it was 2013 when it launched, 2014 came in effect, is now different. Now what happened is Health Canada put the responsibility of the medical authority onto the doctors. They said they're getting out of the approval game, you doctors have to do it. There was a lot of resistance to the doctors because, of course, they don't know, they're not trained on this thing, but the medical professional. So now it has to go to a medical professional, has to fill in a form that's approved by Health Canada, and then the Health Canada, has to approve the system within the licensed producer. The licensed producer receives the forms back. Once all the forms of checks and balances are done, then we are allowed to, a licensed producer is allowed to ship the product to the patient once they qualify. They're allowed to buy it online, like an online pharmacy. So it changed slightly. So now the government stepped back from being the gatekeeper, so to speak, and they put the doctor as the gatekeeper on the medical side. So the doctor is now the gatekeeper on the medical side. They fill in a form, and from this form, what we did is we actually took some data to see, we wanted to know, okay, we had 8 conditions before. How many real conditions are physicians recommending for doctors? We wanted to know. We just want to ask the question. So we started keeping track of the data. That's the list so far. It's 168 conditions that physicians have prescribed medical cannabis for today. And very often, it's in a space where physicians are applying or asking or giving the access to medical cannabis for when the medical system has failed them, or the drugs are failing, they're not working. Or they're in a state where they're getting lots of other medications and still they're managing symptoms and they're still not getting anywhere. So we tried to pool the data. What's the percentage? Well, 58% of the people that are accessing medical cannabis today are using it for managing some form of pain. I mean, it's segmented in a series, but really, it's about 58% using it for managing some form of pain. We have neurologic, about 19%, psychiatric, about 13%, oncologic, cancer at 9%, and the miscellaneous factors about 1%. But by the largest part, most people are using it for managing some form of pain. Now, we have lots of data that goes back, and we've had lots of heartwarming stories of people who have tried it. A child that was 9, whose mother was beside herself. He had Dravet syndrome, 1,100 seizures a day. He was taking 8 different prescription drugs. Costs about north of $8,000 a month to the Alberta government. And when he tried using the high CBD strain that we provided to him, within a week, the seizure count went from 1,100 a day down to 1 a day. And when 2 weeks later, after that, under the physician's supervision, they were able to wean him off all the other medications. And so now he has about a seizure a week by using this particular product. Now, the issue became that she had to pay out of pocket for this. It was cost about $400 a month. And now what happens is that we lobbied successfully that the Alberta Sick Children's Hospital should pay for it. And because they're saving already $8,500 a month. And they agreed. And so now they pay for it on behalf of her son. Because it's a win-win. Province saves money, but his quality of life is back. We also have, on the other end of the spectrum, we have a lot of veterans who use it for managing PTSD. And they're finding that they can get the reprieve from they don't stay on it forever. They stay on it until they can actually get past that dream cycle so they can get healed. And we also have lots of fibromyalgia patients and arthritis sufferers who use a wide range in between. But a lot of them are still at, believe it or not, the 12% THC that was originally supplied from Health Canada, especially fibromyalgia. We have the fibromyalgia, say for whatever reason, that particular one seems to work. Now, that's the history of us getting involved in it to sort of bring it forward. So as a group then, licensed producers are today in the country under the new program. There is 29 licensed producers across the country. Actually, this slide is now a little bit old because now it's, as of yesterday, there's now 7 that can produce oils. So there's 7 that can actually sell oils across the country within the licensed producer framework. That's just to give you a sense of the range of percentages of CBD and THC of the products that are across all of the different companies. There's 78 herbal cannabis varieties currently listed on the different at that time this is an old slide of the 7 licensed producers at the time, but the population is pretty much the same across the board. That's what we tend to see in terms of the variation. Again, LPs are managing mostly just for THC and CBD. By number, there's roughly, Health Canada tells us there's about 30,000 patients in the program today that have enrolled in the program. So their average prescription is about 3 grams a day, and there's, in our case, they're using about 1.1 grams a day is what they're actually buying. And of course, the stats from Health Canada, these are as at the end of September, so they haven't updated them yet. These are as of the end of September. So where's the future going of medical marijuana? Of the medical side? The medical side is going in the direction, I think, of a more generic drug delivery systems. We're going to see more clever systems of drug delivery that are going to be more succinct in their dosing. That's really going to be the future for this product. They're going to become more standardized so that doctors can prescribe succinct dosing in different forms. That's coming for sure. The international community is going to wake up at some point. Right now, Canada is leading the world in this space, along with Israel and the Netherlands, and a few states that are operating only within their state laws. But we're going to see that it's the uncomfortable position that Canada is actually leading, that we're actually going to find that there's going to be a lot of countries interested in following the pattern that Canada is leading in the medical space. Now, our job is really just to focus on the medical side. So we see that as a sort of the next step in trying to educate. How do we tame the shrew, so to speak? How do we move this into the next generation of products that will be more user-friendly and more patient-friendly and more patient? The third thing that's going to happen is you're going to see, I think, a plethora of clinical trials. The U.S. very recently was given lots of power and lots of money, about $500 million to spend on clinical trials for different institutes. We're going to see a large amount of clinical trial data that's supported by public funds to come up with some of the answers, to demystify and to bring more science to this thing. So the scientific community is coming in behind it now, that is getting empowered. And it's not coming from Big Pharma. Because Big Pharma can't get their arms around, part of the problem is patent. Can't get their arms around patenting yet, because it was patented in the turn of the century. 1937, going back to that time, at that time, 25% roughly of all the medicine that was in the doctor's bailiwick was cannabis-based, about 25%. So in 1937, when that came, there was a lot of resistance on the part of the doctors, and many of the doctors actually were fined for resisting the legislation that came in 1937. Now we're just playing catch-up back to that. So it was arguably cannabis and the cannabinoids have been artificially stymied from their development because of started in 1937. They should have patterned along when the opiates got developed, because the opiates are still available today. Now, from a pain perspective, if you think about it, there is, we have the NSAIDs, which are the Tylenols and the ibuprofens of the world, and then we have the Oxycontins of the world. And if it doesn't work in either one of those things, then you're kind of stuck if it's pain management. But after hundreds and hundreds of billions of dollars of research, we still haven't found anything better for managing pain. That's the reality. Now, this particular plant, and the cannabinoids in general, seem to be that it's a suggestive, it's anecdotal, 58% is using mostly for managing some forms of pain. We have lots of unsolicited testimonials from people who were absolutely destitute, and all of a sudden it came in. And it has to do with the fact that they're subsidizing their endocannabinoid system. They're finding some status. A doctor told me the other day, there was a 94-year-old woman who was in for a knee replacement. She has to have a knee replacement. She's waiting 6 months for a knee replacement. She's in excruciating pain. And she was taking breakthrough morphine and 8 Oxycontin a day just to manage the day, and walked with a cane. He prescribed her some medical cannabis. She was using what was called a lower dose of 4% THC and a 10% CBD. She came back 6 weeks later without the use of her cane. Completely managed her pain to the point where she's sleeping at night. No, she still needs the knee replacement. But when she takes her 4 doses a day and she's vaporizing, she's managing her pain, and she has quality of life back. We're finding that some of the patients who are saying our parents on palliative that are suffering and on palliative care from oncology, when they're on these high levels of morphine, they can't have those end-of-life discussions because they're too stoned. And they want to be able to get that where they can have those conversations, make their parents comfortable, but have those end-of-life conversations. That's the compassion that's needed. And I see that this is going to be more and more understanding as we move the needle to making this more standardized as a practice for patients to access to improve the quality of their life. God knows we've got enough suffering everywhere else. Thank you. Sure. Oh, good.
So Brent said he's willing to take some questions from the audience, and I think we've got 15 to 20 minutes or so. If you have a question, try and identify yourself, and if you can, keep it relatively brief so we can get as many questions in as possible.
Yes.
Super brief. I'm very interested in the role of inflammation because I never recognized that. I study schizophrenia in medical history program, PhD here, in collaboration with a neurovirologist in France who's in clinical trials for MS for monoclonal antibody treatment. So we're looking at the relationship between schizophrenia and MS and inflammatory pathways. So if this is working for inflammation pathways, I'm very interested in what that, if you know anything about that. But then the big controversy with schizophrenia then is cognitive interactions with schizophrenia. So I'm just, you know, if there's psychiatric schizophrenia patients taking the disease with the inflammatory pathways, I'm very interested because it's a new research in disease.
Can you repeat that from the back too?
Can you guys hear the question? So the question relates to wondering if there was any evidence in relation to using medical cannabis, either by anecdotal or by scientific, for managing schizophrenia. There is some growing evidence. There was a clinical trial that was recently published, and Larry will have to help me on this one, on schizophrenia, and it was suggestive that the higher levels of CBD helped, very high levels of CBD and very low levels of THC were helpful in mitigating some of the symptoms. It was one clinical trial that we've seen. We do have some patients that are using it, that swear by it, that are using it today. Again, the challenge with medical cannabis in any of these symptoms, as you can see, 168 conditions, and very often the doctor and the patient have to go on a journey. And the patient, to really try this, they have to actually do a trial and error, or one doctor that knows, is experimentation of one. And they have to then take and try the different strengths to dial in specifically what it is that they need to do to manage their symptom. And it actually becomes empowering to the patient. I was surprised when I was talking to the patient, because the patients feel helpless and that they don't have the control of their life and their well-being. And when they start down the medical cannabis path, they find that all of a sudden they got hope. And then they'll go in and they'll actually dial in the specific one that they need, and all of a sudden it works. Bingo, and that's the one they stick with. Now,
research on the inflammatory pathways, I'd be very interested to see what that research is, the scientific research kind of.
Yeah, we certainly, after we can get you some information there, as we have to do a significant amount of research in the drug master file that we have, and in the clinical trial preparation for osteoarthritis of the knee that we did, and a lot of references. But the plethora, the sheer plethora of scientific information is exploding right now, because the world is hungry to find out this stuff. And so the answer is, there could be, I don't know, I don't have it top of mind, but the patients are using it to manage inflammation, yes. Now, so after we can talk, and we can see if we can send you some information. Okay? Yes?
I'm just curious to know if the government has come to Prairie Plant Systems to try and get, like, say, consultation on how they should go about legalization if they want to get input from you guys, the industry.
No. They love that. That's part of the hate part of the relationship. They don't see, because we're now a licensed producer, they don't want to see it inviting us into policy discussions and that stuff. They just see us as a provider on the medical side. You know, we've got a long history of compliance, 15 years of compliance. And, you know, they see us as being somebody that's law-abiding, but trying to follow within that context. But they don't see that we add much value there. So the answer is no, they haven't approached us. And I really don't expect they're going to. Yes?
If marijuana becomes legal, and it doesn't look like it's going to, are you positioning your company to be a legal supplier so I can dial you up and get some of that?
Unfortunately, no. Our mandate has been on medical. The other LPs are betting on the recreational play to come to fruition in the next couple of years or less. We're trying to move more in the direction of the medical and trying to extrapolate the different dose forms in a more medical, succinct way. So we're going in that direction, and then we also believe in the treasure trove of the other cannabinoids that are there. The CBGs of the world that could be antipsychotic to help on schizophrenia. CBG, cannabigerol was one of the ones that suggested as well. Cannabichromine for the different things that we're looking at. So we think the value proposition that we bring is on the medical side. It fits more with our business model too, because we still have other research programs that we have plants that we've designed to make other types of proteins. So that's the model we want to go. We see taking this medical approach, once we dial in some of the more succinct things, to then take and extrapolate that to international markets. So we see that's our growth strategy. So we're not going the recreational route at all. In fact, we look at it from a corporate point of view as being agnostic. We're agnostic to it right now. So we just stick strictly medical, and we want to move down that path and increase the types of products that can come out, and then go to other parts of the world with it. That's our goal.
But wouldn't the recreational market be a lot larger than the medical market?
Well, everybody's entitled to speculate. And of course, Health Canada believes patients in Canada, their expectation is by 2022 that they think there'll be around 400,000 patients in the marketplace today. We think it's actually closer to 700,000. We're a population of 30 million. Okay? Now, if the truism of the baby boomers is true in our developed country, and it's going to be the same thing in other developed countries, we probably have a baby boomer population, and we're thinking it's going to be in the neighborhood of 20 to 30 million people that are going to want to access this in the next 10 years or less. There's going to be plenty of market on this. Now, I can't comment on the recreational side. I don't know how large that is because we don't study that at all. But we know that on the medical side, the numbers are getting staggering. And it's because of this, what's at the base of that? 58% of people using this to manage pain. There is so much suffering still going on in our society that they're not using it. We're not there yet. This is one of those breakthrough things of saying, they haven't found anything better for pain. We're likely going to find the sweet spot for that. And every one of the baby boomers at some point in their life may find that it's going to work for them for managing their symptom. Now, if you talk to the professionals, like Dr. Mark Ware, he says that naive patients, about 35% of the population respond favorably to some form of cannabinoid treatment. A third of them have a negative reaction, mild but negative, and a third of them are, again, neutral. But if their endocannabinoid systems get compromised, then they find that they actually does add some value. So arguably, we think that 35% of the developed population, of the developed world, is going to want to have access to cannabis at some point. So we're focused on that market and those people that we can add value to. We feel good about helping to mitigate suffering. The other side, again, we're kind of blind to it.
What role will patenting the specific chemicals play in the future for medical cannabis?
Well, that's a good question. Patenting is getting to be so difficult right now. What was patented at the turn of the century, like Eli Lilly had patents on tinctures and all those different things. You can't patent a lot of that stuff today because it's in the public domain and the discoveries are made. And then GW Pharmaceuticals has patented a plethora of stuff because they were first out the gate in the UK with Sativex, and of course they got a whole history of patents. The patent space is really going to be, I think, designed around new delivery systems, smarter delivery systems, and perhaps the combinations of the products. Right, or marrying it to another molecule that you can have as a partner. Those things, in my mind, are the things of the future for future patents. But the cannabinoids by themselves, I think that day's gone.
Just kind of a comment about, you said there's 29 licensed producers. Saskatchewan had 2.
We have them both.
So they're both you. So isn't that kind of a misleading? I guess why would you guys have 2?
Because one acts as the production center, and the other acts as the distribution and education center. And so we have to split we just split the activities, that's all. So you have to get licenses for both. The production license can't, we're not allowed the production license to sell directly to a patient under the parent. The Canamed is a wholly owned subsidiary, is the only one allowed to sell to patients.
So there's only actually 28 LPs then, not actually 29? Because license for production would mean they're producing it, right?
No, well, it's still, no, a licensed producer definition just means that their involvement under the MMPR. So the total is 29. So they just are licensed for different things.
So on the 29, if these other companies are doing that, is there actually only 14 actually production facilities there?
They just recently put in 2 or 3 more in there, but there's, I don't have the entire breakdown on everybody. There's 2 or 3 of them that have 2 licenses, but it's because they split the activities, that's all.
But would that make it a dispensary, not a LP though? And why then wouldn't they give more licenses to more LPs that are actually growing that instead of saying that there's 29 if there's only actually 20?
I hear ya, but at the same time, I can't answer that question. It's a Health Canada question. That's that hate part of the relationship, right? So Health Canada is the one, and there is approximately 250 LPs waiting to get licensed right now. And the government is trying to figure out what to do, right? But suffice it to say, I certainly encourage you to contact Health Canada to ask them that question. We just did it to manage how we have to do it. It's because we have to possess the material as we're handling it through the system. and it comes under the regulations. That's all.
Are we doing like human trials, and do you supply your product to researchers and labs? And what are sort of the range of conditions that are being investigated, maybe in double-blind studies, do you know?
Well, we've involved in the first one. It took, get this, 3.5 years before we got the first patient in the clinic when we started. It's a 2A clinical trial, double-blinded, placebo-based clinical trial for looking at osteoarthritis of the knee and pain management for osteoarthritis of the knee. And it's being done on contract with 2 centers, one in McGill University and one in Dalhousie in Nova Scotia. And I would say we're midway through the process. There's going to be a series of them that are also on deck that we know of, and they involve everything from Tourette's to epilepsy to inflammation. But there's a whole host of other ones that we're not involved with.
And given that the different active ingredient seems to be a match for different conditions, do they ask you to try to breed to tailor things to come up with different strengths of the active ingredient?
We're not there yet. I think that, again, these are, what we're finding in the clinical trials is either a phase 1, and there's a phase 2 clinical that we've been working on. There's a phase 4 that Dr. Ware is working on right now for post-market. There have been very few phase 3 studies. In fact, I don't think there's any phase 3 studies been done yet. And that's where the efficacy part of that would come out of. And the phase 3 studies, again, they're very expensive. And that's going to take a huge amount of either public funds or private funds in order to get across the finish line. We're still characterizing what the response is. There's a suggestion now. See, the problem is that we know the CB1 and CB2 receptors and how that works for THC and how we have those working in the human body. What we don't know yet is the receptors for CBD, cannabidiol. We know it works, but there's a bunch of theories around that, and they think that there might be 6 other satellite receptors around them where the CBD is influencing or helping to aid the THC concentration. So again, science is just beginning to understand that. So the clinical trials are coming, but they're also tempered with the fact that we still don't have quite enough information to do all those. Yes?
So related to the patenting question, if we, and you said earlier in your presentation that big pharma is not really involved, but I mean, is there a role for the larger agriculture businesses, like anything like Monsanto or Syngenta or something like that? Like, are those companies actively getting involved in this field?
Not to our knowledge. The reason being is that this, in the way that the medical side is done, again, other production I can't comment, but the medical side has to be done under these certain conditions that meet the GPP standards, which good production practice, which are a greenhouse with all the security. In our case, we use growth chambers with all the security and all the production practice. So they've had a very, it's actually, there's a big security element. So the field grown material isn't on deck right now. That's not. Now, if the federal government changes its mind, that changes everything. But I don't see that changing for a very long time. So the big biotech companies aren't thinking about any kind of field production on this. So they can't get their arms around any kind of business model at this time.
Do you guys use any GMO plants?
No. Not for, we don't use any GMO products in the medical cannabis space. None, 0. They all came from those selections of those 25,000 that we found. Yes?
Say 20 years from now, cannabis has been federally legalized and all the framework is in place. Do you see big pharma getting into this? Going in and developing their own strains and their own varieties to...
It's going to, the thing about big pharma getting involved is they have to find a way they can protect some space to make the investments in the clinical trials, because you got to get, in order to really get it to market, to protect it, you got to get through phase 3, prove that it works, and then you get a drug or a DIN number and you get an indication, et cetera, et cetera. And it's a very long process. Now it used to take only 5 years. Now they're saying it takes a minimum of 12 years to get through that process. And the average drug to get to market is $750 million today. That's what it costs to bring a drug to market through the clinical trial process. So they have to be pretty sure that whatever they're running through the process, they can protect, just from the patenting. So they're going to have to find something that's clever, that's just not the natural THC and CBD, that it somehow protects, something else is protected there, either the delivery system or they're tying it to another compound or something that makes it valuable. But they have to be willing to make that investment in the different gated system to get to that, through that $750 million to make it worthwhile. Then they got to recoup the cost somehow, right? And I got to bear in mind that vaporized medical cannabis is probably the cheapest it'll ever be, because it's the way in which it's the least developed, but it's also the most natural form. Every time you add a step to it, it gets more expensive, right? So that's the problem. But I can see them eventually, when the market gets big enough, yeah, the sharks start swimming. But they have to find a way to get around that. That's why they haven't jumped in yet. Just my opinion. Yes?
And an IP question. Maybe the more appropriate application would be plant breeders' rights to this situation. Has that come up yet?
Yes, we've had some discussions about plant breeders' rights. We clone all our plants. But if you're going to use and sell the seed or sell the plants, I think it makes some sense to go to plant breeders' rights. But you got to have the math. Most of the companies that are doing it are more interested in selling not the seed but the finished products. Right? Plant breeders' rights will protect it, but the enforcement of that is going to become tough. Now, of course, Dr. John Page is doing all kinds of things for DNA fingerprinting and for genomics that we could track it. And I think we're going to see on the plant breeders' rights, the designer plants, for example, where you design a plant to make a certain high level of CBG, for example, cannabigerol. And we're finding all of a sudden, to the earlier question, that cannabigerol, with a very small amount of THC, works as a insomnia pill, right? Well, they're going to want to patent that in some way, shape, or form. But if you can maximize all the production of the channel, all the cannabinoid profile into the plant to just CBG, that would be valuable to, and it could be put under plant breeders' rights in that particular case. Now, you've got to bear in mind from a biology point of view, it's very expensive for a plant to produce one compound that we still don't know what its value is. To a plant, the trichomes, the theory is they were developed or they evolved at high elevations. And they really were, the trichomes were designed to protect the plant against UV radiation. And the psychoactive part was to sort of help mitigate the bugs from chewing on it, right? To make them essentially stoned as they start to chew on it. But nobody really knows why the plant can produce that much on a per weight basis. If you think about it, well, some of the strains we have, the one that we commercially is 22% by weight of THC. That's a highly efficient way of biology to make one compound that has very limited value for that plant. So when you can get a plant, and that's our whole MO and business model of designing plants to make certain therapeutics, when we think that you have a plant that can actually design it and you can clone it, it's a very, very efficient way of manufacturing drugs. And one of the designer ones, those are going to be the ones that will be important.
Yeah, but you would also only have to have this certain type of chemistry to them too, right? It might still be appropriate for all types, but for sure.
Can I just ask if this product's replacing steroid medications for arthritis, MS, do you find that?
We find it's, well, in general, I can't speak specifically to the steroid medication, but the individuals where they find that they've got limited success with whatever medical regime they're using, including steroids, that as soon as they find that there is symptom relief using a dosable form of medical cannabis, they tend to reduce those other prescription drugs by a significant amount.
And the long-term impact of steroid medications on the immune system, and that it's actually exacerbating the disease, schizophrenia, and MS in the long term, so that this product, if it provides relief and it doesn't engage that process in the immune system that the steroids do, that it might actually be medical.
It's entirely possible that could be done in the future. I think that we're going to see that there's going to be lots of information as this plethora of stuff comes to the fore. I think we're going to see a lot more information coming forward.
I hate to cut it off, I'm sorry, but we have a half-hour break now where we can talk out here, and then at 3:30, folks, we're going to have some panels, and Brent is going to participate on one of the panels again. So join me in thanking him once more.